Welcome to Dr. Jeffrey Roth's Looking Good and Feeling Great podcast, live from Las Vegas, with his co-host, Darrell Craig Harris.
Hi, this is Dr. Jeffrey Roth, your board-certified plastic surgeon in Las Vegas, Nevada, and we're at it again.
Yes, and we're actually we're tooling away. We've actually got quite a few downloads. I think we've almost reached 75,000, which is really exciting.
That's very exciting. So everybody that's within the sound of my voice, thank you for making this happen, and please tell your friends. We like to think we're putting some good stuff out there, and so by all means, tell your friends. And if you have something that interests you or something you want to hear about or a question, please go ahead and give us a call, and we're happy to go ahead and get that done.
Yeah, it's exciting because, there's a lot of interest about, the medical field in general, but also plastic surgery, obviously. Sure. And there's a lot of, misconceptions and all sorts of different things. And one of the things we did this week was actually we filmed you doing surgery, doing a breast reduction.
Yes. Which
was my first. It was an interesting and fun process.
How do you feel?
It was good. I think, I didn't know how I was going to react exactly because it is surgery. Watching that is an interesting adventure. But there was a lot of interesting things for me. One of them was marking the patient, all that kind of thing that you have to do to make a successful surgery. Can you kind of walk us through that process?
Sure. It was an experience for me as well. I've kind of resisted for years and years having cameras in the operating room, et cetera, et cetera.
Right.
Although many of my peers have done that for years, et cetera. And again, it depends on how you frame it. And of course, the patient is always paramount. And so whatever they're comfortable with is they're the boss.
Yeah.
So that's step one. But there are a particular patient. She was an absolute sweetheart. And she was very much into the educational aspect of all of this because she says, well, I want people to see this because this was my journey that I went through. And so she, of course, was thinking about this for quite a long time. Et cetera, had a couple kids, and with kids, sometimes you'll get bigger breasts, and sometimes they will droop. And so what we do with a breast reduction, and some of these folks are thankful, happy as patients, is one, it's the pendulousness. It's not just the mass, but it's also the pendulousness of the breast, which I think really hurts their neck and all that stuff. So it's like a backpack and the straps are too long. Right. And you put the straps back where they're supposed to be, and then it's where it's supposed to be on the chest, things feel better. So,
yeah, because she mentioned she had a lot of years of back pain and issues, right?
Bra strapping and back pain, all that kind of good stuff. And so with one operation, you're able to really help somebody and make a big moment happen in their life. So, and that's what really has always kept me coming back, is able to make a difference. But to your point is preoperative planning, perioperative planning is always important. From the first time we meet, talking about the different aspects of the surgery, what to expect. Are you a candidate? Are you on any drugs that would preclude you? Okay, so once we get past that hurdle, okay, that sounds great. You're a candidate. Let's go to the operating room. What plan are we going to do? How big do you want to be, et cetera, et cetera. Day of operation, again, as you saw, we went ahead, measure. They told me a long time ago that a good carpenter measures twice and cuts once.
Right.
And so that's what really subscribe to. So you see that we check and we check and we recheck again. And we do that.
What I liked about that too in that process was that you kind of used that time to reassure her. I liked your whole tone. You kind of set a nice tone for her. So, because of course they're going to be nervous.
Sure.
And do you find that to be really important pre-op?
Absolutely. Because people come in anxious, and people, again, it's a dark room. So if we can go ahead and turn a light on in that dark room, and so that it's not so scary. And again, for me, it's like going to the office. And frankly, I'd rather be in the OR than the office most days, right? Most surgeons would. So for me, that's the fun part, doing this. As well as I actually like talking to patients. Some guys don't. Right. So for me, it's nice to have the interaction. But yeah, so you're there. It's a strange environment. They tell you, oh, by the way, take off your clothes and put this thing on. So it's we're going to put an IV into you. Like, well, yeah, that kind of hurts.
The whole thing is
so it's a surreal kind of experience all around. So I, as the kind of familiar face, I've seen him before. Well, that's my doctor.
Right.
Say, yeah, no, this is what we're going to do. And this is, and we basically review the plan. Mm-hmm. I show them the preoperative photos. We measure. I explain the measurements, and basically go over some of the post-op planning too. Okay, yes, you can eat. We'll go ahead and talk to your ride home to tell him or her what we're doing with drains, et cetera, et cetera. Okay. Basically, just try to inform people best we can so that forewarned is forearmed is basically they know what's coming next, and so it's not so scary.
Right. And do you find that a lot of women that, especially for well, not only breast hogs and that kind of thing, but do they come in really pretty prepared, a lot of research already done on their part? Or
It depends.
How is that?
There's a wide variety of folks like, oh, hey, I just thought about this the other day, to folks that come in with dossiers.
Right, because they've been wanting to do it for years.
Years. Yeah. I mean, especially some of the moms that, I've been thinking this since my first kid 15 years ago. I've been thinking about, depending on the surgery, whether it's breast reduction, whether it's breast augmentation relift, otoplasty, which is the ear pinning. Some folks have been thinking about this almost their whole lives.
Sure.
And so they finally, it starts with an idea, and it starts with talking with, most times it's with family and friends, and then it's the internet search, which can be good or bad. And then they thankfully wind up in a board-certified plastic surgeon's office. And there it's, are you a candidate? All those dreams, hopes, expectations. Are you a candidate to actually go ahead and do this safely?
Right.
So for me to go to the operating room, it's got to be two things. It's got to be safe and effective. If it's not safe, if she's got blood thinner on because she just had a heart condition, well, guess what? She's not going to the operating room.
Sure.
It has to be effective.
Yeah, because it is elective surgery.
It's elective surgery, and I have to be effective. I have to go ahead and say, I'm going to take you to the operating room, and I'm going to go ahead and make this look different, and I think it's going to look better and come out nice. Otherwise, it's not worth going. Because it's not, we talk about indications for surgery, the whys,
Sure,
right?
Right.
Gunshot wound, you got to go fast, right?
Sure.
Cancers, you got to move fast. So in aesthetic surgery, we have the luxury of time that we're able to, okay, well, let's get you off the blood thinner, et cetera, et cetera. Let's get you to the cardiologist and get you to be the best you that patient can be. So in that regard, that is really a blessing that we have over in the aesthetic surgery world.
Yeah, and also, part of that, I would imagine, too, is creating realistic expectations also about, post-surgery recovery. Can you talk a little bit about that, how you deal with that with patients?
Sure. So the expectations, I think, management expectations is key. And I like to, and I tell staff all the time, is we like to, under-promise and over-deliver wherever we can. And most folks nowadays are, to your point, well-informed. They've probably seen 2 or 3 other plastic surgeons. They've been through the internet. They've been on the ASPS site or the ASAP site. So they have an idea of the conduct of the operation where we're going. Now, some folks come in and go, Doc, just fix it. And some other folks are like,
Right.
Oh, I want a 325cc implant, high profile, made by a guy named Bob. And you're like, okay, well, wait a minute. Where'd that come from?
Exactly.
So again, you're kind of all over the place.
Sure.
But reasonable expectations, is this, can I get my breast lifted without scars? Well, no. Well, I don't want to scar. Well, okay, we have to talk about that.
Right.
And see what everybody's different threshold is for that sort of thing. There are girls that come in, we're talking about breast stuff, with a couple of bananas, and they want to look like Carmen Electra, and you're like,
Right.
Okay, so we can get from point A to point B, but not necessarily to point C. Okay,
Right.
And again, it depends if they've had 4 kids, if they've been smokers, if they've been on steroids, et cetera, et cetera, et cetera. And that's where the reality comes in, and that's where the consult is so important, because you then, hopefully, you've seen this before, you have some judgment, et cetera, and you can basically paint a picture of, okay, these are what you can actually expect. Because what you don't want is expectations to be high, the reality to be lower, and that gap there is a surprise.
Right.
And
You want
that's
to eliminate as much surprise as possible.
sadness. It lives there, and surprise lives there, and so that's not where you want to be in that.
Sure.
Now, things happen, right? So there's a 1% infection rate. So you do 200 cases a year. That's 2.
Right.
Okay?
And if you're one of the 2, it's...
and if you're one of the 2, that's 100%
Right,
for you,
exactly.
right? And it's a 100% issue. So yes, we get some effect. Thankfully, rarely and less than most, but I would be lying here if I said that. Oh yeah, no, I do scarless, painless, surgery with no. So you have to go ahead and paint a proper picture of folks of what to expect. First post-op, typically the first 3 days out of any operation stink, right? So you're hurting, you're sore, you're not pooping yet, et cetera, et cetera. Okay, so that's fine. And then things get better and better and better, and depending on, of course, the extent of the operation, et cetera. But then, some folks like, oh, geez, I'll get my surgery Friday and I'll be back at work Monday. No,
Right.
It doesn't work that way.
Yeah, because you want the results. That's a big part of it too. I know obviously you have to explain to them, like, there is a recovery period, and if you don't respect that,
Right.
you're going to cause problems, right?
And gals, especially gals, some guys, but gals come in later, usually on the revision, go, I didn't listen the first time around.
Right.
I was messing around, on day 6, day 7,
Something
when
happened.
I should have been. Yeah, and so they're like, next time. And so I'm like, oh, can I put you on the website and tell everybody else? So yeah, and again, I don't say things to be a meanie, or something. It's a matter of, hey, we've done this 1,000 times before. And so in our bell-shaped curve, this is kind of what works is, not doing, back handsprings on day 3, that kind of stuff.
And like it is an investment. They're investing in their body and that kind of thing. And you definitely want to create a situation where they're going to have possibly the best outcome that can
absolutely
happen.
It's time, it's energy, it's effort, and we say that all the time is get your universe in line. In other words, get mom to come in to help with the kids, get coverage for you at work so that you can concentrate. Your job should be going ahead and recovering from the surgery, and not having to run after 6 kids.
Sure.
And,
you need to be able to switch that off.
And 2 in diapers and be lunch. And so I tell people all the time they really have to get their ducks in a row. And we're happy to help. As far as, hey, I think I need some help. Can I get a nurse? Okay, fine. Hey, I need one of those lazy boy recliners that you go ahead and pull a lever and it kind of springs you out. Okay, so we can help. The thing is, and we talk to those folks about, okay, who do you have at home? What are you going to do? How are you going to help?
So it's really a holistic approach. It's not just about doing the surgery.
And some people don't realize what I mean. I can't go ahead and pick up a roast and move it. So Thanksgiving's coming. So it's all of that.
Right.
So preoperative, perioperative planning, I like to think paramount and gets us our ducks in a row.
What about the subject of pain management post-surgery? Well, one thing is people getting addicted to pain medication, which I'm sure you're aware of that as a potential thing. But how do you deal with pain management? What's the what's the advice? What's the approach for you?
It's all a part, and again, talking about perioperative, or by perioperative I mean before, during, after the case, right? So that is a key to the perioperative world. Now, number one is people don't want to be nauseous. Now, even more than pain, people don't want to be nauseous. And so the anesthesia guys and gals and the plastic surgery guys and gals have really, I think, focused on postoperative nausea and vomiting, right? So even if you do the great surgery and they get a great result, they're like, oh man, I was sick as hell and blah, 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 blah. And that's not a good experience, number one. People would rather be in pain than be nauseous. So nowadays, before, during, and after the case, the anesthesiologist will give you all sorts of medicine for that. We don't use some of the gases that we used to cause nausea before. So we're at least aware of that. People are more hydrated. And so basically for us, the nausea thing is key. So before, during, and after, we really try to knock that down. Okay, great. So now if we have the nausea in control, let's talk about pain management. So it's still surgery. So yes, now some folks are like, Doc, I took 2 Tylenol, that was it.
Everybody's so different with that.
Everybody's so different. So that's step one. Step 2, some people come in with pain management issues or they're on pain pills and stuff, and we'll talk about that in a second. But the garden variety guy that comes in, yes, you're going to have some surgical pain because I'm a nice guy, but I took a knife to you, right? And then 2, depending on the operation, for example, breast dogs. Okay, well, we put them underneath the muscle. They're going to spasm a little bit. So what do? We give not pain medicine. We go ahead and in the operating room, we actually put a numbing medicine in there. It's 0.5% Marcaine, so it lasts for a little while so that it kind of numbs the area on the inside so they don't start that.
You kind of get ahead of
the get ahead of it. So that's step 1. That's a non-penalty move. Then number 2 is pain medicine afterwards, of course. But we also give muscle relaxers. And the muscle relaxers I found to be really important in breast surgery, especially underneath the muscle, etc. So we can keep people out of spasm, we can keep them out of pain, and they use less pain medicine.
Yeah, because that would be the last thing you would want after post-surgery, the spasm aspect.
Exactly. And then tummy tucks. Tummy tuck's a big incision. It's a great operation. We also put the muscles back where they're supposed to be. So we give people muscle relaxers there as well because sometimes that'll go into spasm. And we used to do this thing called a pain pump, which was like this ball of Marcaine, again, which is a numbing medicine, and it would drizzle out a little bit of, and you put a couple of catheters and a ball, and it would drizzle out about 1 cc to 3 cc's an hour of this pain medicine for 3 days, which was great. And that helped a lot. And now they came up with a stuff called Exparel, which is a drug, which is basically that same stuff, but suspended in this lipid sort of stuff. So in other words, it lasts for about 3 days.
Oh, good.
And so now we go ahead, during surgery, we inject it all around the wound and the incision and all that stuff. And so people have a lot less pain for 3 days. And they love that. And there's less narcotics, so there's less
chances of having issues.
There's 1 chance of having issues, but then 2 also constipation, all that stuff that comes with it. And then the other thing too is you're not going to get hooked on 3 days worth of Schedule II narcotics.
Right.
If you have pain, right? Where guys and gals get in trouble is they take it electively or they get hooked on it because they take a little bit too much or a long period of time, et cetera, et cetera. So typically for the acute pain, surgical pain that we go through, and chronic pain is a whole different subject.
Right.
And they have a whole, branch of medicine for that. But if we're talking surgically created acute pain, we're usually able to go ahead and get people from the Schedule II narcotics off, and it's okay to take them for a little while, right?
Right. Because sometimes you do need that.
You have to.
Right.
I mean, thank God we have them.
Sure.
But the thing is to use them when you need them, not use them, when you.
And if you're going to write the prescription, you do it for a few days, not a month.
Well, yeah, and so I'm a little nutty about that because I see people back in 3 days, then I write them a new prescription in 7 days, and especially in Nevada, they have a whole bunch of different laws because of that sort of thing, and so we've all really tightened down. But having said that, we've come up with alternative solutions so that people aren't in, a ton of pain and agony.
Right. I mean, it's great now that there's so many different options. It's not because it used to be. I would imagine that most doctors would just turn immediately to the pain pills.
Yep.
But now we know that the issues that come with that.
And those folks that specialize in this have really kind of shown us the way. And the other thing too is some folks come in like, doc, I've had this back injury, I'm on X that I take every day, and they go to a pain doc. And so typically they'll have a contract with that pain doc saying, hey, I can't get pain pills anywhere else, right? And so then we work with that pain doc saying, hey, I'm a nice guy, but I'm going to go ahead and cause some additional pain here. And then they, because they're the experts, will go ahead and manage that.
Right.
But now we have a whole division of medicine with literature and science background that actually does that and does a really good job with that.
Right.
So typically people shouldn't be afraid of pain in as much as we can acute surgical elective surgery pain because we can manage that pretty well.
I think it seems like management is actually the key word.
Yeah.
You're not going to make it go away, but you can definitely make it where it's you can sleep and you can do what you got to do.
And you shouldn't, because when I was a general surgery resident and we were doing big trauma surgeries and doing liver resection, all kinds of stuff, basically you give pain medicine because otherwise it really hurts. But two is you give pain medicine for breathing. And what I mean by that is on a 1 to 10 scale, you want the pain to be about 3 or 4. Yeah, I had a big operation. I got some pain, right? If the pain's a 10, they're not breathing. Okay, and that's bad. They get pneumonias and all that stuff.
Sure.
If you completely schnocker them, okay, and their pain is a 0, they're not breathing, and that's not really good.
Right.
So basically,
you
want
that zone.
Yeah, you want it right. That exactly right. You want to titrate to effect. You want to titrate to about 3 or 4, and I'm breathing. And they're making me cough. It's a little uncomfortable.
And then you're able to sleep and do it.
Right. So yeah, exactly right. So yeah, nobody wants to torture patients by any stretch, but the thing is you want to go ahead and titrate the good and the bad with all of that.
Another subject is actually, and your office manager, Jamie, put our list together today, but there's some good stuff on here. And one of the things was what to look for when you're choosing a surgeon. What are some of the top things you advise people? I mean, obviously they're coming to see you, but then they're also asking you advice about other surgeons, that kind of thing. What are some of the top things that you would suggest them to look for when seeking out a surgeon? Sure.
And we're talking about, elective plastic surgery, et cetera, because that's what I kind of do most.
Sure.
So with that, you want to go ahead and find yourself a doctor who can do the operation, does enough of these operations, et cetera, et cetera. So a good starting point, can be family and friends. It can be your regular family practice doc or primary care doc. And that's okay.
Right.
But if I was to say, all right, well, I've been thinking about it, the first thing I would do is go to the website of the American Society for Plastic Surgeons, ASPS, which is, I think, plasticsurgery.org. Anyways, so ASPS, American Society of Plastic Surgeons, because that website has all the people on there are board-certified plastic surgeons.
Right.
The other website that I like to do is ASAPS, the American Society for Aesthetic Plastic Surgery. All those folks are, again, board-certified plastic surgeons that specialize in aesthetic surgery. So those two sites are really good. They have lots of good information about the procedures themselves and then the docs and all that sort of stuff. So that's the place to go, and that's a safe place. Why? Because everybody there is board-certified in plastic surgery.
Right.
They've done a complete plastic surgery residency. They've graduated from it. They've took the plastic surgery boards, et cetera, et cetera. So those guys are bona fide, and gals, are board certified folks, and that's the first start.
And we've talked about that before, but the board certified thing is really important. And I know, and we have some of the, I won't say TV surgeons, but TV surgeons, some are, some aren't.
Right.
We won't name them, but I mean, that does bring up that point.
And so now they may have a terrific Instagram account, or they may have a terrific webpage, and blah, blah, blah.
Right.
But when the rubber hits the road, when the knife hits the skin, you want the guy or gal to really kind of know what they're doing. Yeah. So, and the reason I think Jeffrey thinks that you get a board certified person is because they've been there, done that, and one is they can recognize problems and then fix them. Mm-hmm. Okay, because if you get injections in your butt in the back of a tile shop and something goes wrong, where are you going? Okay, so that's where you're going with that. But more importantly, oftentimes we can go ahead and detect issues before we even go to the operating room. And that's why you've been in my office, we sit down, and it drives my office manager crazy. I spend way too much time with the patient. Right. But we talk about history and physical and the drugs you're on. And wait a minute, tell me about that again? Oh, it's just maybe a throwaway comment. But all of a sudden, like, no, wait a minute, let's explore that. Right. And so that may push us one way or another. And people forget to tell you things and stuff. That's why. And
sometimes they'll bring family members. The family member will say, "Oh yeah, that was that one time you had that problem."
Oh, happens all the time
with the anesthesia.
I mean, the classic. the classic stuff. Yeah, no, we've detected. I mean, we find stuff. I mean, we find cancer. We find blood problems. We find stuff. Yeah, the classic is the guy comes in and especially on general surgery. And I said, any previous surgery? Sir, no. And he's got a big scar from his throat down to, he had
there was a bypass.
Right. And so the wife usually goes, well, what about the thing? You remember your heart stopped? And you're like, I know. Well, that's an issue.
Particularly with men, right?
Oh, yeah. Guys are the worst. So having said that, yeah. So that's one thing. Is to go ahead and find yourself a board certified plastic surgeon. So step one. From there, I like going and selecting out. Now you can get to their websites. You can see where they trained. You can see when they got boarded and what years there were, et cetera, et cetera. So that's a good thing. And then you can pick out. I like picking out 2 or 3 folks and going and seeing them because with elective surgery, the patient's the boss. So he or she are interviewing you. Okay, and so they can go to a doctor.
You are literally hiring them for a
job. So we're like roofers, or something like that. You get 3 estimates. So basically, so you can go to Dr. A, Dr. B, and Dr. C, and who you like. And it's not only just the doc, but also guess what? You're going to have to interact with the office staff, and you're going to have to get to where they're ever going to get to. You have to know about a follow-up plan. You have to know about all this stuff. Do they return, calls? Is the place clean? So all of that gestalt is important. And so when you go into the doctor's office, look around, listen. So I always tell folks, go see 3, guys or gals, and then write down notes afterwards because you'll forget. Oh, well, was he the guy that said this, or he's the guy? Because you go to a plastic surgeon and you may have 3 different answers for what particular problem. Right. Because we're all trained a little bit different and we have different experiences. And for example, in general surgery, there's really one way to take out a gallbladder, right? Okay. In plastic surgery, one of the classic questions we get on rounds is, give me 5 ways to close that wound. And you say, oh, well, let's do A. And like, can't do that. Oh, do B. Nope, you already took out the blood supply. Darn it. So we're taught to think like a chess match, right? So in that regard.
Multi-level.
Right. So in that regard, some guy may do plan A first, plan B, plan C. He's not wrong. It's just a matter of, okay, this is where I trained. This is what's worked for me, et cetera, et cetera. So some folks come in and they get a little confused. They say, gosh, I've been to 5 guys and I got 6 opinions. And I'm like, well, we all are saying mostly the same thing. It's just kind of how to get from point A to point B.
Right. Do you find, we'll talk about the breast thing because we just dealt with that, but do you find yourself always trying to minimize scarring? Is that kind of a goal overall?
Oh, sure.
I would think it seems obvious, but
sure. So as plastic surgeons, we create scars, right? So that's how the body heals up tissue, and they've been working on scarless healing for years and years. Dr. Mike Longacre and his team, and so many other folks have been working on that for years and years. They've kind of got it down if you're a fetal sheep, and the reason why they use a fetal sheep is because that research is because cleft lips and palates. Right. And so what they're trying to do is actually get there as early as they can, fix the cleft lip and palate without any scarring. Okay, so they're like, well, is it, what is it? Is it the surgical technique? Is it the fact that it's the fetus? Who knows? So, but they've been working on that for years. And as plastic surgeons, even general surgeons or orthopedic surgeons, GYN surgeons, we all hate scar, right? Because scar leads to bowel adhesions, scar leads to contractures, especially in the burn unit population. If you have a burn around a joint, you want to do everything you can so you don't get a scar around that to keep the mobility and extension and everything else. So we hate scar. And so as plastic surgeons, we try to create as least amount of scarring as we can, and we get called upon to hide it. So as a plastic surgeon, we still make scars, but we try to hide it in lines that people eyes wouldn't necessarily notice.
Sure.
So in wrinkles and crinkles, for example, blepharoplasty, great incision to make because you're going to hide it in the crease that people normally have on their lid and into the crow's foot a little bit. Right. So that's a great scar. So basically you try to do that. Even on the breast, you go ahead and you try to hide the scars where the areola meets the rest of the white of the breast or in the inframammary fold.
But also, obviously, it depends on how much you're going to have to do.
And as plastic surgeons, we're used to working through male slots, and that kind of stuff. Yeah. But even the general surgeons and orthopedic surgeons and GYNs really kind of showed us the way too. Is all with the laparoscopic surgery and the robotic surgery now. You make itty bitty incisions and you can do the operations, and it's great. So that's the thing. My dad had his total hip done, right? Okay, and so I go over to his house to change the dressing. I'll come change the dressing. Okay, sure. So I come over there, and the thing is about 4 inches long. And I'm like, where's the rest of it? And he said, no, that's it. I'm like, wow. You're kidding me, right? And so I ran into his surgeon. I'm like, really? It's this big? He says, oh, yeah, Jeff, you have no idea. He says, the instrumentation has gotten so good now that we're able to go ahead and do that through itty-bitty incisions, which helps rehabilitation and everything else. I went and I saw my dad right after surgery, and he's up in, like, the chair, right? That kind of like,
that's funny.
That chair. And I'm like, what are you doing up here? He says, they put me here. I'm like, So I went ahead and I found the nurse. I'm like, is he supposed to be up there? I'm like, yeah, no, they're up in around 2 hours now, doc. I'm like, okay.
Yeah, it's funny how technology changes, and obviously with the endoscopic surgery, all those laparoscopic, all those things have really probably changed everything for everybody, right? Yeah.
Now, to your point with the scars, is okay. So we're going to go ahead and make a scar. So the one thing is make it as small as you can, put it in a place as you can, and then perioperatively. One is keep tension away from it, because tension is the enemy of scar of good wound healing, right? So face lifts, breast lifts, tummy tucks are all by definition on tension. So that's why we don't have, especially our breast surgeries, lifts, reductions, and our tummy tucks, we don't want them twisting so much, because twisting is going to be tension across the wound. So we have one do that. 2, there's also in the burn population, there's compression garments with silicone in contact with them. And so that's really good about kind of modulating the scar as well. And there's massage of the scar. So in our office, we actually have this stuff called biocorneum, which is a silicone base with some medicine in it, which cuts down on redness. And so we really like that for the scars. So main thing also is to keep them out of the sun. Because 1, it's bad for scar healing in the first place, but then 2, it also darkens up the scars as well. So if you can keep people out of the sun, out of the UV light, that's a big deal too. Now, scars typically look their worst at about 4 months, and better again at about 10 months. So people will come in at 3 to 4 months and say, hey, it's looking a little red, doc. The answer is yes, it is, and it's expected, because that's when the collagen is most disorganized and heaped up and red. After that, things get more linear, much more straight, etc. And we follow scars along, and especially in our patients of color, our Hispanic folks, our Asian folks, our black folks, you got to watch out for hypertrophic scar and keloid scar. So for them, you tend to tape things up a little bit longer. If they turn a hair, you can hit them with a little bit of intralesional steroid. In other words, you inject the lesion with a little bit of steroid to go ahead and mellow that out. So yes, the one is to look at it, recognize it, and if need be, then go ahead and interact. But it's a partnership between you and the patient. We talk about perioperative care as well. It's like, okay, you got to take care of this thing as well too.
Right. So. Yeah, the ultimate goal is to get them where they're going to be happy with the results, obviously. With surgery in general, what's your advice as far as really recovery? Is it just, like you said, generally not stretching, staying out of the sun, but what are some of the other things? Is there any kind of vitamin stuff? Or
so
nutrition, holistic?
Yeah, nutrition is really important. And when I was doing a lot of reconstructive surgery, I did general surgery first. Of course, the place where I trained, there's a place that developed TPN, which is the one that they stick a needle into your arm, and they can actually feed you all your nutritions and everything else like that through there, because sometimes you can't use your gut for whatever reason for a long period of time. Okay, so they beat us with nutrition when we were there. So now, fast forward, I'm a plastic surgeon, and I'm very much into nutrition. So when I very first came to town, I worked with the PT folks because they were in charge of, pressure sores and all that kind of stuff. And they knew I was around because all of a sudden I was ordering albumins, pre-albumins, and transferins, which are indicators of, how are we doing nutritionally lately, right? Because if somebody has a albumin in their, which is a protein in the blood, and if your albumin stinks, you can be the best surgeon in the world, and you can swing the best flap in the world to go ahead and cover up this bed sore, and it'll fall apart.
Really a holistic.
It's right. So I tell folks all the time, yes, you have to have protein, you have to have some carbohydrates, you have to have some veggies to get the vitamin C and all that kind of stuff to go ahead and make this thing work. I tell folks all the time, and especially my models that come in, I say, look, now's not the time to be on the kumquat diet or some crazy diet that sometimes you guys are on. It says you need calories, you need some protein, you need some, et cetera, to go ahead and heal this thing up. And even some folks, we delay. When I was doing reconstructive surgery, like the little old lady with the bed sore, right, who's in the nursing home, who's been eating saltines for 6 months, she's not going to be able to heal up a darn thing, right? So you have to get some protein shakes into her. You have to get her up and moving around. You have to get her, otherwise, again, you can be the best surgeon in the world. I am not, but I've been trained by a couple of them. Again, getting back to perioperative care, planning, et cetera, nutrition for me is key. Not smoking is absolutely key.
Yeah, we've talked about that before, and explain why that is.
Well, yeah, especially things that are on tension, right? So there's this old surgical adage, and I tell the medical students all the time, you want to cut on tension and sew on no tension, right? So when you've all seen how things work, you take a scalpel and you press the skin and you take tension, you put tension on it to go ahead and do that. You don't want floppy skin because you want tension,
nice,
right?
Nice straight.
Right. So you do your thing and whatever you do, and then to sew it up, you want to have things on no tension, right? You don't want to go ahead and have to, crank it together. So facelifts, breast lifts, tummy tucks, we talked about smoking, tobacco use. And by tobacco use, I also mean snuff, I mean vaping, I mean any of that stuff. Anything nicotine patches, gum, it's all nicotine. Now some are a little better than others. We can argue about that, but yeah, it's nicotine. It's a vasoconstrictor, right? So basically, you don't want a vasoconstrictor because when you put things on tension, again, facelifts, breast stuff, tummy tucks, tension's the enemy of good wound healing. And so what you don't want is anything that's going to vasoconstrict and not get the blood flow to where it is. If, for example, I won't do facelifts on smokers because, and again, not to be a hard guy or whatever like that, but it'll fall apart. Same thing with breast surgery, et cetera, it's bound to fall apart. So that's important. Again, we're talking about perioperative planning and what to do to get yourself in the best thing. And some people say, should I get 1,000 international units of vitamin C? And they smell of cigarette smoke. You're like, okay, time out. Say, well, first you got to do that first. And then, and then maybe, 90 pounds. And you're like, okay, and then you have to go ahead and get your nutrition on. And then we can talk about, Linus Pauling and vitamin C and all that kind of good stuff.
How can people find you to ask you questions and find you online and explain how that?
Sure, we're all over. You can't miss us. We're all over. First, the cornerstone is our World Wide Web address, which is www.jjrothmd.com. That's jjrothmd.com. That has our website. Lots of information there. We wrote it purposely, so there's lots of information. And you can contact us through there. We also have social media aplenty as far as Instagram and Facebook.
Your social media guy's awesome.
He's spectacular. So right there. Anyway, so Instagram, Twitter, Facebook, all that stuff. And so we have information there as well. So check that out. And then we still use the telephone. Amazing. And so you pick up the phone and give us a call. We're happy to answer. We like questions. How's that? So we like questions. If there's a question, a concern, or you saw something in some crazy magazine or on TV or on the internet, and say, does this make sense? Call us. Okay. So, and I sell this all the time. I said, I'd rather people call me, even if it's something I don't do, as opposed to winding up in the back of a tile shop.
Right.
And when people come in, I tell them, hey, I'd rather you spend 20 minutes with me than 20 hours on the internet, right? Because the internet's great, but sometimes it can lead you in really weird and wacky places, right? So again, you got to go ahead, do your due diligence, but then, come to a board-certified plastic surgeon, whether it's me or somebody else. By all means, with us, we like going through the whys and wherefores and all that. So yeah.
Awesome. Thank you, everybody, for joining us today, and we look forward to talking to you on our next episode.
Sounds fantastic. We'll see you soon.
Have a great day.
Thank you so much for joining us. For further information, please visit the podcast website link for Dr. Jeffrey Roth. See you next time.